reviewed some of the nomenclature, particularly the names of different layers of the bowel wall. You'll have to know that. You'll be very familiar with that. We're going to use those same terms throughout the lecture. I believe we left off just about to start Mallory-Weiss tear syndrome.
Yep.
Yeah. So the lacerations of the esophagus. We're talking about pathology of the esophagus in general. Mallory-Weiss tear syndrome is another interesting pathology that's very common that affects the esophagus. It's a condition in which there's a deranged vomiting reflex. And this deranged vomiting reflex results in the tearing of the wall of the esophagus. Now, normally when we vomit, the lower esophageal sphincter will relax, and then the stomach will violently contract to eject the cunt. In this Mallory-Weiss syndrome, the LES does not relax, and the stomach still violently contracts. And so now the stomach is contracting against the mechanical obstruction. And typically what happens is that the distal esophagus and proximal stomach are over-distended. Over-distended, the epithelium, the mucosa tears. Now, most of the time, the tear itself is limited to the mucosa. The biggest problem you have is some bleeding. It normally isn't very extensive. Sometimes the bleeding can be extensive, but normally it is not. The bigger problem is when the tear is not limited to the mucosa. Sometimes the tear will become transmural. If the tear is transmural, then chyme is ejected into the mediastinum, and it results in first a chemical mediastinitis and then an infectious mediastinitis. And this can be fatal. Ultimately, it results in something called Voorhees syndrome developing, and that's universally fatal if it's not treated. Now, typically when these tears develop, the orientation of the tear in the esophagus is parallel to the longitudinal axis of the esophagus. Let's take a look at this. Take a look at it in diagrammatic form first. And this is the result of a deranged vomiting reflex. Someone has to vomit, the lower esophageal sphincter should relax before the stomach violently contracts. But with Mallory-Weiss tear syndrome, the LES doesn't relax, it keeps its tone, and the stomach ends up contracting against a mechanical obstruction, which over-distends the distal esophagus and proximal stomach. Here's a little diagram showing you the distal esophagus, the proximal stomach here. Again, when the stomach violently contracts against an obstruction, the esophagus and proximal stomach are over-distended. When that happens, the mucosa tears. Now, usually these tears are indeed limited to the mucosa, and perhaps there's some bleeding. But really, the bleeding itself is not that extensive. It could be, but it usually is not. The bleeding will control itself. Eventually, the bleeding stops. Sometimes the bleeding is more extensive, and that can cause problems in and of itself. But a more serious complication of this condition is when the tear is not limited to the mucosa. It becomes transmural. If that's the case, then when the tear completely goes through the wall of the esophagus, the chyme is ejected into the mediastinum, and again, that will cause first a chemical irritation of the mediastinum, and that will be followed by an infectious mediastinitis that eventually develops. Excuse me. Let's take a look at what these tears actually look like. So we're looking at an endoscopy of a person with a Mallory-Weiss tear. You can see we're looking at the distal esophagus, proximal stomach, and you can see some normal mucosa here. It's kind of got a whitish pink color. That's because it's invested by a stratified squamous epithelium. Everything looks good here. It's normal. There's no inflammation. But over here, you can see there are these tears that have their axes parallel, oriented and parallel with the longitudinal axis of the esophagus. That's typical of a Mallory-Weiss tear. Here's another view of a Mallory-Weiss tear. Again, we're looking at the distal esophagus. There's a stomach down here. This is the distal esophageal mucosa, nice and normal. And again, you can see these tears that are oriented parallel to the longitudinal axis of the esophagus. Now, this type of Mallory-Weiss tear syndrome typically develops in people that have a deranged vomiting reflex. And the most likely individuals that are going to develop a deranged vomiting reflex will be those that are consuming a great deal of alcohol. Alcohol interferes with this reflex. So you have an alcoholic that vomits, they're more likely to develop this Mallory-Weiss tear syndrome. Now sometimes the derangement in the reflex can develop on its own. Person is constantly vomiting. Sometimes there's a lack of coordination of the reflex after a while, resulting again in contraction of a contracting stomach against a obstruction. But more often it's associated with this alcoholism. Okay. Let's talk about some of the complications. Again, most of the time, these tears are just limited to the mucosa. There's some bleeding. The person will be vomiting some blood. Usually the bleeding isn't that extensive, but in a subset of cases, it can be, and that in itself can be a complication. The bigger problem, though, is when the tear is transmural. Then the chyme enters into the mediastinum through the tear, and it causes this mediastinitis that becomes septic and is universally fatal if it's not treated. This condition is referred to as Voorhees syndrome. Voorhees syndrome is a complication of a transmural Mallory-Weiss tear. Let's take a look at Voorhees syndrome. So this results in a transmural tear of the esophagus in which chyme is injected right into the mediastinum. Here's a CT scan of someone with Voorhees syndrome. You can see anterior, posterior, there's right, there's left. We can see we're at the level of the heart here. You can see different chambers of the heart. Okay. You can see the lung parenchyma here. We're actually catching the diaphragm on the right side here tangentially. That's what this opacification is here. Over here you can see the descending aorta, and that's the esophagus right there. Notice that in this area around the esophagus, around the descending aorta, you can see this air density. That shouldn't be there. That's air in the mediastinum. That's a pneumomediastinum. How did it get there? It got there from the GI tract. When the tear developed, and the stomach ejected chyme through the tear, not only did it introduce chyme, but it introduced air as well. And this air will track up along the esophagus and descending aorta. Sometimes the air is so forcefully ejected from the stomach, not only does it get into the mediastinum, but it gets into the subcutis, and people develop subcutaneous emphysema. Emphysema just means full of air. And so the subcutis becomes full of air. And when the subcutis becomes full of air, and you push on that area, you can hear crepitus. You can hear the crackling of the air. This is all a result of the air being ejected through the tear into the mediastinum, possibly dissecting right through the subcutis. Okay. Voorhees syndrome is a serious complication because unless it's treated, septicemia will develop, and ultimately the person will die from a septic shock. Okay. The presentation of Voorhees syndrome includes Mackler's triad. And typically with Mackler's triad, you have a history of vomiting. That's the whole problem. Vomiting with a deranged vomiting reflex. First, we'll have retrosternal chest pain, possibly upper abdominal pain. That's from the tear and the chyme entering the mediastinum. And they have subcutaneous emphysema. You can discover that on your physical exam, just palpating the chest. You'll hear crepitus, crackling. You can also see it on a plain film radiograph of the chest. You'll notice there are these speckles of air densities on the chest radiograph. They shouldn't be found. Other symptoms will include dinophagia, that's pain with swallowing. So you got a tear in the esophagus, it's going to be painful to swallow. There'll be dyspnea, Eventually, people will develop a fever, and again, if this isn't treated, they'll develop septic shock. So the workup. You suspect someone's got Mallory-Weiss tear. That might be in someone who is an alcoholic, who has been vomiting, who's complaining of pain with swallowing, who's vomiting out blood. You might suspect Mallory-Weiss tear in such a person. One of the first things you're going to do is get a standard clean film radiograph. You might see subcutaneous emphysema if it's a transmural tear. You'll see air in the mediastinum. Also, you just might see a pleural effusion with time. Sometimes people with Voorhees syndrome also develop a pleural effusion. Here's an example of a radiograph of someone with a pleural effusion. And you can see right and left over here. The right lung field looks good. You can see just normal vascular markings, normal hyaluronic densities, nice lucent air-filled lung. Over here, you can see part of the lung field looks normal. You've got normal vasculature. The hilar area that you can see here looks normal, but you'll see this opacification here. This is fluid around the lung. This isn't the pleural cavity. It's not actually in the lung. It's in the pleural cavity surrounding the lung. And you kind of get a sense of that because the distribution of this opacification doesn't really correspond to any lobe on the left side. What you do see is this kind of curve over here in the contour of the opacified area. And that kind of is reminiscent of a meniscus, and that's exactly what it is. There's just fluid accumulating in the pleural cavity, creeping up from the most dependent portions of the pleural cavity upward. And you can see this kind of curve, again, that's kind of reminiscent of a meniscus. That's fluid in the pleural cavity, not in the lung. And again, this is also might be observed in Voorhees syndrome. CT scan, again, remarkable for pneuma mediastinum. You'll see air tracking around some of the great vessels in the esophagus, which is because of the forceful ejection of time and air through the transmural tear. Now, ultimately, you want to find the location of the tear. Now, you can do this a couple of ways. Your first inclination might be to perform an endoscopy. An endoscopy will allow you to directly visualize the tear, but there might be a problem with that. If you suspect a tear and you perform an endoscopy, you might make the tear worse. The reason for that is when you perform an endoscopy, you have to inflate the esophagus with a certain amount of pressure of air. If there is a tear there, or there's a weak part of the wall, you could make the tear worse just by adding pressure, intraluminal pressure to the esophagus. And so that's not the first thing that you might want to do it that way, but that's not the first thing you should be doing. What we want to do is we want to locate the tear with a less problematic imaging study. And that would be to use an upper GI series. Upper GI series, you ask them to swallow a contrast agent. You take a radiograph, and you can actually see where the tear is located based on where the contrast is leaking out of the esophagus. You can easily locate the tear that way. But there's another complication with even an upper GI series. Normally, you would want to use barium sulfate. Barium sulfate's a superior oral contrast agent. You ask them to swallow the barium leaks out where the tear is. The problem with barium sulfate is it's not very water soluble, and it's also somewhat inflammatory. And if it leaks out of the esophagus into the mediastinum, it's going to cause inflammation and fibrosis. And so instead of using the superior dye barium sulfate, you have to use a more water-soluble, less quality contrast agent. It's called gastrografin. Gastrografin is more water-soluble. If you suspect a tear, you can use gastrografin. Gastrografin will leak out where there's the tear. And if it does leak out in the mediastinum, well, it's not such a big deal. It's not going to be inciting an inflammatory response that ultimately results in fibrosis. Now, if you do perform a gastrografin study and you discover that there is no leak, there is no tear, no evidence of tear, at least with gastrographin, then you can follow that up with a barium swallow with a superior dye. And again, double check to make sure there is no tear. But you first must perform the study with gastrographin. You have to have some reasonable evidence that there isn't a tear before you go on to use barium sulfate, which is a superior dye. And this will minimize some of the complications of your workup. And if you're absolutely positive that there is no transmural tear, then you can perform the endoscopy. Usually you don't have to do very much. If there's no transmural tear, you just allow the esophagus to heal on its own. Whatever's causing the vomiting, you put a stop to that. That's how you treat it. You don't even have to perform any kind of surgical procedure. If there is a mucosal tear, you discovered the tear, you located the tear, and it's bleeding profusely, you can use some sclerotherapy to stop the bleeding, so that's not a complication. So there's a whole series of steps in a specific order in which you work this problem up. If you go out of order, you start to increase the probability of complications of your workup. Okay? So the order is specifically designed to minimize complications and any kind of exacerbation of inflammation. Any question on Mallory-Weiss? Mallory-Weiss tear syndrome. Okay, let's talk about esophageal varices. Now, you've heard me mention this a couple of times. We've talked about this in the context of portal venous hypertension. Portal venous hypertension is usually caused by some problem with the liver, and very often it's going to be some scarring process occurring in the liver that causes the resistance of blood flow to increase through the liver, and as a result, blood coming from the GI tract through the portal vein to the liver encounters a lot of resistance of blood flow. This results in an increase in pressure of the portal venous system. Portal venous system communicates with many other venous plexi in the system, including a set of submucosal veins in the distal esophagus and proximal stomach. These submucosal veins, under a tremendous amount of pressure, become dilated and tortuous. We call them submucosal veins, dilated submucosal veins. These esophageal, these variceal dilated submucosal veins can be relatively asymptomatic in the beginning. But these veins are located right underneath the mucosa, and when they become dilated, they push the overlying mucosa into the lumen of the esophagus, and that puts the mucosa in a very exposed position. When people eat, a large food bolus comes down the esophagus, this exposed mucosa gets hit. Food bolus comes down and starts hitting the exposed portion of the esophagus. And as a result of that trauma, the mucosa tends to be eroded, and that directly exposes the dilated submucosal vein. Dilated submucosal vein is now sticking in the lumen of the esophagus. Now remember, this submucosal vein is under unusually high pressure. It's under portal hypertension. And it constantly then gets hit by a food bolus passing down the esophageal tube until the wall also is eroded. And eventually, there's a point where the wall is eroded so much, its structural integrity is compromised and it ruptures. And when it ruptures, suddenly these asymptomatic esophageal varices become very symptomatic because they'll present with extensive bleeding into the esophagus. And people will start vomiting whole blood, hundreds of milliliters of whole blood. Not just pink fluid, whole blood. And very often, that will not stop until some sort of intervention is carried out. Okay, let's have a look at these esophageal varices. Again, main problem, they're caused by portal venous hypertension, usually caused by liver cirrhosis, scarring of the liver, causing and increased resistance of blood flow through the liver. And let's take a look first at a normal specimen. So here's a typical normal specimen. We're looking at a resected distal esophagus and stomach. The specimen's been opened along the longitudinal axis. You're looking at the mucosal surface of both the esophagus and the stomach. So here you can see the distal esophagus. Okay, you can see the mucosa looks white in color. That's because it's infested by a stratified squamous epithelium, which has that white color to it. Then you come to a point where there's an abrupt change in epithelium. We go from something white to something kind of orange tan. And you see there's a sharp interface between the two. That's the esophagogastric junction. Some people call it the gastroesophageal junction. On a radiograph, this area would appear as a zigzagging lucency. And so radiographically, this part of the anatomy is called the Z-line. So whatever you want to call it, Z-line, esophagogastric junction, gastroesophageal junction, it's what's referring to this area where there's an abrupt transition between epithelial types. Now everything here looks good. If I study the distal esophagus, you can see it looks like it has a corrugated topography. Means it's kind of got its corrugated kind of surface to it. That's to allow for distension. Food bowls coming down here is going to stretch the esophagus. The esophagus has to be designed to stretch without tearing the epithelium. That's what that's for. It's got, again, a very convoluted topography. Taking a closer look, you can see these features better. And the white epithelium of the esophagus versus the orange tan color of the epithelium of the stomach here. And again, you've got that really abrupt change in epithelial types of the esophagogastric junction. Okay? Everything is normal here and normal here. I see no evidence of esophageal varices. When someone develops portal venous hypertension, the submucosal veins become distended, and again, they push out the overlying mucosa, which constantly gets eroded by food dropping down the esophagus, constantly traumatizing the surface of the exposed mucosa. The mucosa erodes away. That leaves the exposed vein. And eventually the vein is eroded and eventually will rupture. Let's take a look at this. Here's an example of these dilated submucosal veins, the esophageal varices. Again, we're looking at the same type of specimen, distal esophagus, proximal stomach, and again, the specimen's been opened. So now we're looking at the mucosa, specifically the epithelium of the esophagus, and there is the stomach down here. Some parts of this esophagus look fairly normal, kind of white, stratified squamous epithelium you can recognize, but there are areas of this esophagus that don't look normal. Here, and here, and here, and over here, it looks like you've got some cystic structures sticking out from the wall of the esophagus. Those are not cysts or varices. They're parts of the vein that are bulging out into the lumen of the esophagus. And all of the overlying mucosa is completely eroded away. You can see the area is very erythematous. That's due to the trauma from the food passing down the esophagus, just constantly eroding the mucosa. And that irritates the area, and again, ultimately exposes the underlying varice that's pushing out the mucosa. Now these veins, they're under a lot of pressure. And so they don't, as you know, veins don't have much of a wall design that would give them much structural support against high pressures. And so they're likely to rupture to begin with. But if you add to that the trauma of food passing down the tube, further weakening the structure of the wall, eventually they rupture. And when that happens, the esophagus here is going to fill up with blood. And this will be whole blood. It will probably be in the volume of hundreds of mLs, and people will suddenly start vomiting up whole blood. And I emphasize whole blood because there are many other conditions in which a person vomits up blood, but it's usually a pink fluid. This is not pink fluid they're throwing up. This is whole blood they're throwing up. Okay? And they're throwing up hundreds of mLs of it. Okay. something's not done about this, they potentially could bleed to death. And again, usually the way we would address this problem is to either stick a catheter down the esophagus with an inflated balloon and try to tampen on the bleed, or we would inject the area with some sort of sclerosing agent and allow the blood to clot in that area. Eventually, we'll have to do something about the pulmonary hypertension. Pulmonary hypertension is causing these esophageal varices. We actually may have to put in some sort of shunt that will redirect blood from the portal vein into the venous system by bypassing the liver altogether. And that will reduce pressure in the portal venous system, but it has complications of its own. Okay, let's take a look at the radiographic appearance of these varices. Varices can be pretty expensive. You probably can only appreciate the extent of these varices on a radiograph. Here's an upper GI series showing you someone with these varices. Let's first take a look though at a normal esophagus. So again, we have a barium swallow here with a normal esophagus. This is the distal esophagus here. This is where the LES is located, and here of course is the stomach. Okay, you can see the distal esophagus fills uniformly with barium. You can't even see the topography of the esophageal lumen here. Everything looks really smooth. This strictured area is just the lower esophageal sphincter opening up. And as it does, you can see it's filling barium right into the proximal stomach. Looks good there. There don't seem to be any problems. Over here, you can see an upper GI series of someone with esophageal varices. And again, we're looking at distal esophagus here. And you can see this esophagus is not filling uniformly with barium like the normal esophagus. Instead, you can see these areas here. These are all filling defects. And they're areas not filling with barium because there's something else there. And it's a wall, a venous wall that's sticking out into the lumen that's displacing the radiopaque dye. So that area of the esophagus does not pacify. So they're called filling defects. And you can see how extensive the filling defects are throughout this esophagus. It's not just one area, it's throughout the entire length of the distal esophagus. Okay. Questions on that so far? A couple of things to emphasize. Okay, it's again, common condition in people with liver cirrhosis. Liver cirrhosis is the scarring of the liver. Most of the time, liver cirrhosis, of course, is caused by alcoholism. 67%, 2/3 of people with liver cirrhosis eventually will develop these esophageal varices. And again, these things are relatively asymptomatic until they rupture. Perhaps someone with esophageal varices will feel something when they swallow, but they're not usually complaining about anything. It's not something that would concern them. It's not something that overtly gets their attention. And again, everything is asymptomatic until they rupture. Okay. 50% of people with liver cirrhosis will die from hemorrhaging due to these ruptured varices. Okay. Any questions on that? Okay, let's discuss esophagitis, inflammation of the esophagus. Common condition, particularly in people over the age of 40. Many things can cause inflammation of the esophagus. The most common thing that causes inflammation of the distal esophagus is uncontrolled GERDs, gastroesophageal reflux disease. GERDs is a condition that's caused by an incompetent LES. The LES is supposed to clamp down and prevent any climb from the stomach from refluxing up the distal esophagus. When the LES resting tone becomes insufficient, the LES opens up and allows this acidic chyme to reflux up the distal esophagus and cause a degradation of the stratified squamous epithelium of the esophagus. The epithelium just simply degenerates, can extensively damage the distal esophagus to the point where it actually causes scarring and stricture. Usually, if an LES is going to become incompetent, it's going to be after the age of 40. A lot of things happen after the age of 40. The LES can become incompetent after the age of 40, and progressively becomes more and more incompetent as people age. And this promotes GERDs. Let's take a look at what the esophagitis looks like. What happened? Did we skip a?
Mm-hmm.
Yes, we did.
Yeah.
All right, let me go back to that. While I've got the introduction to esophagitis, let's just take a look at esophagitis. And we'll go back to Plummer Vincent's. A section through the esophagus, and we can see here we've got the lumen of the esophagus up here. Okay, and we have got just the epithelium. This is just the epithelium. It's the first layer of the mucosa of the esophagus we're looking at. Okay, you can see the epithelium consists of these squamous cells. They're parts of the different layers of the stratified squamous epithelium. But you also notice there are a lot of other cells in here. A lot of cells that particularly have eosinophilic staining cytoplasms. Those are eosinophils. When the esophagus is inflamed, the inflammatory infiltrate is mostly characterized by the presence of eosinophils. Kind of unusual. We would expect maybe neutrophils or lymphocytes. But in the case of the esophagus, esophagitis is often characterized by an eosinophilic infiltrate. Now, depending upon how bad the inflammation is, the eosinophilic infiltrate will be accompanied by a proportion of neutrophils. The worse the condition, the greater the proportion of neutrophils. Now, I'm looking at this section. I don't see a whole lot of neutrophils, but I see a whole lot of eosinophils. So maybe it's not that bad in esophagitis. But this is how we would diagnose the esophagitis. We'd look at the mucosa, particularly the epithelium, and you'd see it's infiltrated with a lot of inflammatory cells, most of which are eosinophils. Okay, again, most of these conditions caused by GERDs, we get this incompetent LES, and it causes reflux. Now, there are other conditions that can cause esophagitis, but they're not nearly as common compared to, say, GERDs. GERDs is pretty common. I'm sure you know several people in your social group that have gastroesophageal reflux disease and complain about it. It presents as kind of that retrosternal pain. It's kind of colicky. It comes and goes. That pain is caused by the distal esophagus going into a spasm. The acid bombardment causes the esophagus to just occasionally goes into a spasm. When it clamps down hard, people feel that burning pain. And then the esophagus kind of relaxes, and it seems that a part of the pain goes away. That's typically how GERDs will present. And you know, GERDs is responsible for most of these cases of esophagitis, but it's not the only thing that can cause esophagitis. There are certain systemic conditions that can cause esophagitis. Uremias, for example. High blood urea nitrogen levels, they can irritate the esophagus. Something mechanical, like a feeding tube, can cause an esophagitis. If it's not properly rotated, it's not, a feeding tube can cause an esophagitis. Also, there are certain types of infections that can cause an esophagitis. Infections, generally we don't see in immunocompetent individuals, but we do see in immunoincompetent individuals. For example, some common infectious agents that can irritate the esophagus in immunoincompetent individuals would be Candida albicans esophagitis or herpes esophagitis. In fact, these are actually very painful conditions. Now, these conditions do not normally occur in immunocompetent individuals. In fact, Candida albicans esophagitis and herpes esophagitis are considered conditions that are indicative of an immunocompetent host. These conditions cause extensive ulcerations throughout the entire esophagus, not just the distal esophagus. Let's take a look at this. Again, you can see this on a radiograph, as you can appreciate the extent of this on a radiograph. Again, here's a normal esophagus. It's open. You can see here we've got there's the distal esophagus. The distal esophagus is here. Over here, you can see the esophagogastric junction. You can see it presents as a lucency that zigzags kind of back and forth. This is also known as the Z-line. Okay, that's more of a radiographic term. And of course, down here, this would be the stomach right over there. Okay, this is a hybrid study. It's a study in which the person has swallowed this contrast agent barium, and then subsequently you have air introduced in the esophagus. So it's kind of a double contrast study. And again, you can see the lumen kind of radiopacified by the barium, and then you can clearly see the esophagogastric junction there. Over here, you have a similar study, only this has been done on someone with herpes esophagitis. And you'll notice the pattern here of opacification is different. You'll see lots of very opaque areas that are white, and you see areas that are kind of very lucent. They're very prominent. The contrast between the two is extremely high. These areas where you see this high opacification is areas where the contrast is pooling. And those areas in which it's pooling are ulcerations. So the esophagus is accumulating barium in ulcerations. You can see how extensive the ulcerations are. And that would be someone with like a herpes esophagitis. It must be extremely painful for this person to swallow. Okay, any questions on that? Okay, before we go back to Vincent-Plummer syndrome, let's just continue and talk about some of the complications and presenting features of GERDs. Okay, so the presentation usually is heartburn. And most of these conditions caused by GERDs. Heartburn is that pattern of pain I described. It's a kind of a retrosternal pain. It's usually colicky, got a burning sensation to it. It's caused by a spasm in the distal esophagus. The esophagus kind of clamps down, and that's painful, and then it relaxes, and the pain seems to go away. Sometimes the pain is confused with that of a myocardial infarction. The biggest complication of esophagitis caused by GERDs is a metaplastic transformation that occurs in this area. If you have someone with GERDs, and they have this distal esophagitis caused by the GERDs, this area of the esophagus, which is normally invested by a stratified squamous epithelium, undergoes a metaplastic change. The squamous epithelium is changed to a metaplastic columnar, mucus-producing epithelium. It's called columnar metaplasia, columnar metaplasia of the distal esophagus. The epithelium has some other names, but there's one name for this metaplastic change that's more commonly used than others. You know what it is? That's Barrett's esophagus. Barrett's esophagus, you hear a lot of discussion about Barrett's esophagus. So what's the big deal about this metaplastic transformation? It's only a metaplastic transformation. It's one that it develops as a result of the body trying to protect itself from this acid. The squamous epithelium is really designed to protect protect from acid, so the stratified squamous epithelium changes into a more protective type of epithelium to protect against that acid, and that happens to be a metaplastic columnar mucus-producing epithelium. It's just a metaplastic transformation. So what's the big deal? The big deal is that when someone develops Barrett's esophagus, they have a 40-fold increase in developing a type of cancer in this area. It's called adenocarcinoma of the esophagus, and that's the big deal. Okay, questions on that? Let's take a look at this Barrett's esophagus in more detail. And we'll take a break. Let's have a look at Barrett's esophagus. Let's first look at what it grossly appears to be like. Again, here is a section through the distal esophagus and proximal stomach. And if you take a look at the proximal esophagus, again, you're looking down at the epithelium. It's kind of white. That's because this is invested by a stratified squamous epithelium. That looks good. Down here, you can see the stomach. It's invested by this orange tan type of epithelium. That's an acid-producing epithelium. That is normal. But in between the normal esophagus here and the stomach, you have this area right over here that kind of has a mucilaginous surface to it. It's neither stomach nor is it really normal for esophagus. This is the metaplastic epithelium. This is the area of the metaplastic epithelium. This is an area where the stratified squamous epithelium has become a mucus-secreting columnar type of epithelium. And instead of having a white surface, you see this kind of red mucilaginous appearance. This is the area where the metaplastic transformation has occurred. That is Barrett's esophagus. You can see it here in the diagram. Again, we got the distal esophagus, the stomach here. We got some normal esophagus over here. We got stomach, which is normal down in here. And again, in between, we have this area of erythema with a mucilaginous surface. That's the area of the metaplastic transformation. That is what we call Barrett's esophagus. Usually, this area that's mucilaginous red is described as a velvety red color. A velvety red color. And it's got a mucus kind of appearance. That's the area of the metaplastic transformation. Okay. Let's have a closer look at this metaplastic epithelium. I'm going to take a section right through. Here's a section through that velvety red mucilaginous area of the esophagus. Okay, you can see the lumen of the esophagus here, and we can see different layers of the esophageal mucosa here. Okay, there's the epithelium. This is the lamina propria. Okay, you're looking at part of the mucosa. Look at the epithelium. Is that a stratified squamous epithelium? Nope. You don't see any squames there. What kind of cells do you see? No. Yeah, you can see these tall columnar cells, and they're mixed together with these goblet cells. So you got these tall columnar cells kind of mixed together with goblet cells. That is the mucus-producing columnar epithelium that is metaplastic. And again, develops from GERDs. This epithelium is more protective than the squamous epithelium, so the body switches from the squamous epithelium to this mucus-producing columnar epithelium to protect itself from the acid reflux. Now, we can call this Barrett's esophagus. We can say this is distal metaplastic columnar epithelium of the distal esophagus, distal metaplastic transformation of the esophagus. There's actually one other name you can describe this with. If you take a look at the architecture of this mucosa, you'll notice the epithelium, of course, is columnar, but you'll notice the configuration in which it's arranged is somewhat reminiscent of villi. You see these structures here? Don't they look like villi? If you examine the epithelium even closer, not only do you see you've got this villus architecture that's reminiscent of the lower GI tract, but The epithelial cells themselves have microvillus brush border, just like the enterocytes of the lower GI tract. So you have an overall architecture, a villus architecture that's reminiscent of the lower GI tract, and the columnar cells themselves look exactly like enterocytes because they have microvillus brush border. And so there's an alternative name for this condition. Barrett's esophagus, metaplastic transformation of the distal esophagus, or you can call it intestinal metaplasia of the distal esophagus, because the epithelium is very similar to the epithelium of the lower GI tract. So you got three names for the same thing: Barrett's esophagus, columnar metaplasia of the distal esophagus, intestinal metaplasia of the distal esophagus. Anybody can use any one of those terms, any one of those phrases. Be prepared. It just means the same thing. If you understand what the pathology is, you won't forget. Okay, let's finish up with this and take our break. Promise to give you a 15-minute break. Okay, so we talked about the presentation of esophagitis, especially when it's caused by GERDs. It's kind of a colicky pain with retrosternal. Barrett's esophagus, it refers to that metaplastic transformation. The workup for Barrett's esophagus. Okay, you want to go down and check out the area with endoscopy. You have someone who's got long-standing GERDs. The concern is that someone's going to have this metaplastic transformation. So you want to document that with an endoscopy. Your major concern is not the metaplasia itself, but rather the increasing risk for the development of adenocarcinoma of the esophagus. Anyone who has this Barrett's esophagus automatically has a 40-fold chance of 40-fold increase in the chance of developing adenocarcinoma of the esophagus over a control subject that does not have this metaplastic transformation. And the reason for this is this metaplastic transformation can go on to become dysplastic. And you know, dysplasia is the forerunner of cancer. And in this case, that's a columnar kind of glandular epithelium that's going to evolve into an adenocarcinoma, a glandular type of cancer. Okay? Different ways you can deal with it. Usually if you find dysplasia, you can just use some sort of ablation procedure to destroy the dysplastic cells, just like you would with cervical dysplasia. If the person just has a metaplastic type epithelium, then generally you just check it. You just keep track of it. You follow up with the individual every year or so, depending upon the extent of the disease. And if they do develop some sort of dysplasia, then you can treat that. Obviously, you also want to make sure you reduce the damage that's being done. Maybe you put the person on antacids to try to lessen the damage done to the esophagus. Right? Ultimately, the consequence of individuals that have Barrett's esophagus, a subset of them will develop this nasty cancer, adenocarcinoma of the esophagus, and it just has a very poor prognosis. So whatever you can do to prevent that cancer from developing is almost justifiable. Okay, any questions on that? Okay, let's take a break and then I'll talk about pulmonary Vincent's syndrome.